The reason I want to talk about spinal infections is because I think this is, it's interesting. I actually trained at one of the leading transplant centers in the world at the University of Wisconsin. They do a ton of transplants there. We didn't see a lot of infections there. But now that I've been in private practice out here in the community, we get a lot of consults on spine infections. It's impressive. We have a very active population here, an older population. And so it was interesting to me. I think this is a very relevant topic, even though it's kind of boring. I think for everybody in the community, including ourselves. So hopefully it's educational, despite its boring topic. In general, it's not a very common cause of back pain, as you can see here. It's only 0.01% of all things that we see. And typically there's an anatomical classification scheme out there for defining where the infection is itself. We talk about the vertebral column versus within the spinal canal, the disc space, or then whether it involves the adjacent soft tissue. So I'm going to cover the majority of these, not all of them, because some of them involve pediatric topics as well, which we don't see a lot of up here. But the vertebral column infections can typically be pyogenic or non-pyogenic. Within the spinal canal, it's an epidural or a subdural, or in an intramedullary, meaning within the spinal cord itself in the tissues. That's extremely rare, and only about 100 cases have been reported of that ever in the literature, so we're not really going to talk about that. The disc space, you can have spontaneous adult discitis versus childhood discitis, and obviously those that happen after surgery, like a post-surgical discitis. And then obviously those that involve the soft tissues of the cervical, thoracic, or lumbar, paraspinal tissues, which I'm not going to talk about as well, but can be presented in the hospital as well. Typically, the pathophysiology for these, there's typically 3 routes that will get there. Hematogenic spread, meaning through the blood. Typically this can be from a remote infection, like an indwelling catheter, someone with a PICC line, or somebody that has a urinary tract infection, or an IV drug use. It's about 50% of presentations. There's a contiguous spread, meaning it goes from adjacent tissue structures. So if you have like an open sore that will get infected, that's about 30%. Invasive procedures where we get involved with surgery, post-operatively, and then the remainder of them are unknown etiologies. The most common predisposing factors for this, typically IV drug use is one of the things we talk about the most, but obviously as we get older, advanced age puts you at higher risk as well. Diabetes, we see some in spine trauma as well because they'll have an adjacent open wound. I know you have a dirty wound that's affecting the spine. Alcoholism, immunosuppression, obviously, as it knocks down our ability to fight infections. Renal insufficiency, and COPD. Typically, a single pathogen can be isolated, but sometimes if you have, say, an open sore or something where you have multiple microbes that can infect the spine, it can be multiple, but most of the time it's Staph aureus. That's the most common cause of osteomyelitis or bone infections, greater than 50% of the time. And we're now seeing a rise in the MRSA rate, so not just MSSA, which is sensitive to antibiotics, but those that are now MRSA. As you know, people are getting that more in the hospitals, and that's also becoming a big problem in terms of the infections being involved from MRSA as well. That's now increased up to 40%. It used to be about 15 to 20%. Staph epi, common source just from our skin flora. Gram-negative organisms like E. coli from our urinary tract infection, but these are typically in post-operative or immunocompromised patients. Pseudomonas among drug abusers. And then obviously there's low virulence sort of skin flora that we see in neurosurgery. Propionibacter, this sometimes we see with shunt infections with hardware. It's a very sort of difficult bug to get rid of. It just kind of is low grade. And oftentimes presents sort of in a delayed manner. And then Mycobacterium tuberculosis, which we don't see a lot of in this country, but typically like third world countries like India and Mexico actually is where they reported the most. In terms of the work of an imaging studies, plain radiography versus an MRI scan. Of course, you can use a CT scan, but I think we've now got the technology at our hands where we pretty much get MRIs on everybody. And you can see that the sensitivity and specificity from an MRI scan is actually the best. An X-ray can help you localize or at least start there, but it's not going to be very specific. Sometimes the imaging quality is not great, and the differential is so wide that people end up getting a CT or an MRI scan anyways, and I think we just jump right to the MRI. There was actually a big group that was put together in Italy back in 2009. This was a group of spine surgeons, interventional radiologists, anesthesiologists, some nuclear medicine doctors, and ID doctors. And they wanted to get together and sort of put together a guidelines scheme for the ways to manage these. And this is sort of the highlights of that meeting. On the next slide is actually the flow diagram, which is kind of a busy slide, but this is within their paper. Kind of essentially what they said, in terms of imaging studies, the real diagnostic gold standard is MRI with contrast. That's going to be the best thing, just like I was talking about. You can use a PET scan or a CT scan to help you sort of differentiate between high-stage degenerative disease versus an infection. if the MRI is not really helpful in diagnostics, I don't think we've ever gotten a PET scan to help identify it. Sometimes because they're not even available that easily, sometimes you have to wait days for the PET scanner to come around or somebody to be able to do it with the radionuclide drugs. Typically what you want to do for looking at the treatment efficacy, whether you decide if you're going to do antibiotics or surgery, you're going to want to do a PET scan or a CT or an MRI scan. You're going to do it initially, and then you're going to treat the patient for a couple weeks. They can do it after about 2 to 4 weeks, repeat the imaging studies, and then you can do it 6 to 12 weeks if you've done surgery. Typically, you can do a CT-guided biopsy before starting antibiotic therapy. That way you have isolated an organism, you can figure out the sensitivities. You haven't, in theory, sterilized the system yet. And that helps with both histological and sort of microbiologic diagnostics in order to be able to sort of target your therapies. Antibiotic therapy is typically the mainstay for a lot of these, but otherwise we get involved as surgeons when we have to help with a wide abscess, meaning a large abscess, which we've seen some that extend all the way from the cervical down to the lumbar spine. If the patient presents with any sort of progressive neurological deficits, that's always typically a surgical indication. You're not just going to treat that patient with antibiotics. You're not going to get there fast enough. If they have instability or a deformity, so sometimes I'll show you some pictures of this. Patients can come in with pretty eroded bone. If they're demonstrating any type of instability, you're not just going to watch that patient necessarily. Sometimes the need for diagnosis actually comes from us as well. If they do a CT-guided biopsy of that tissue and they don't isolate an organism, sometimes we can go in there and actually do the surgery and get more tissue to help sort of diagnose if possible. And obviously if treatment failure from a conservative standpoint fails, then surgical intervention is also indicated. Like I mentioned, I'm not going to go through this, but that's pretty much the flow diagram of what I just mentioned. So I'm just going to go over some individual specific topics with osteomyelitis, discitis, and the epidural abscesses. From pyogenic infections, typically the incidence is about 1 in 100,000 to 250,000. It's about 2 to 8% of all osteomyelitis cases, and typically there's a sort of a double peak there. Young people, younger than the age of 20, and then there's a large peak between 50 and 70. Like I said, we see a lot of older patients now, very healthy, that are coming in with these infections. And the real sort of reason that it comes in is typically from the blood supply. Like I was mentioning earlier, the vertebral bodies are typically way more involved in the posterior elements of the spine, about 95 versus 5%. And it's interesting that the most common location is actually within the lumbar spine, despite the fact that the thoracic spine is the largest component of the spine. The lumbar spine is almost 50% of the infections, the thoracic spine is about a third, the cervical spine is about 6%, and the junction between the thoracolumbar space or the lumbosacral space is about 10% total. Most of the time it's from a hematogenous spread, like I said, from bacteremia. Goes in the high vascular region and spreads to the disc and the adjacent body of the bone. And typically it can then, if it progresses before it gets diagnosed, this will continue to spread into the adjacent soft tissues as well, and paravertebral soft tissues. And then if this continues on, it can then even involve the spinal canal, and I'll show you some pictures of that. Like I mentioned, the UTIs are typically, I think, the most common thing people get treated for a UTI. You'll hear about them getting treated several weeks ago or several months ago, and they'll present with this progressive back pain, fevers, and you find out they have an infection. So that's one of the most common sources. A soft tissue infection, 13%. A URI can also cause this, about 10% of the time. Obviously, there are post-surgical interventions, and then spine trauma, like I mentioned before. And the most common isolated species is Staph aureus. The diagnosis is often difficult in these patients. There's oftentimes a very slow progression, like I was mentioning. They have sort of this low-grade symptomatology that presents for about 2 to 3 months. It can range anywhere from 2 weeks, and they've reported up to 2 years before somebody's actually come in with this. Obviously, if you get up higher in the spine where the spinal cord and space is smaller, it's going to be diagnosed sooner, such as the cervical spine. Obviously, the lumbar spine, where there's just the conus and the nerve roots, you have much more space for an infection to sort of dwell down there before you'll come in and actually identify something. The most important thing is not just the pain and tenderness. Everybody comes in with back pain complaints, things like that. You're not going to sort of feel that they have an infection necessarily. But the back pain with the fever, I think, is really sort of where you want to raise your sort of alarm. Weight loss, not oftentimes complained about. Like I mentioned, neurological symptoms are unusual initially, especially if it's in the lumbar spine. The cervical and thoracic will typically present sooner, but it's not really observed. It's observed in less than half of the patients. And there's typically an epidural abscess in about 20% of the patients that have an infection of the bone as well. About 4 to 17% of patients will have some type of neurological deficit. Obviously, the risk of paralysis is going to be higher in patients with higher risk comorbidities, diabetes, rheumatoid, steroids, being over the age of 50. And obviously, as you go higher up in the spinal canal, like I mentioned, typically the paralysis occurs from the cord compression from kyphosis, where the bone starts eroding, the patient starts leaning forward, similar to what Alan was showing those pictures earlier, or if they have some type of instability where they're actually digging their cord from the motion of the bones together. There's infiltration of the neural elements, the nerve roots themselves, or the spinal cord. And sometimes you actually can thrombose the venous supply to the spinal cord from the infection, and that causes sometimes paralysis as well. In addition to imaging studies, which is mentioned below, you're going to want to get laboratory studies, at least for a baseline. ESR, CRPs typically will be followed. These can be extremely high, 85 to 93. Obviously, you want to get blood cultures on the patient. Typically, we'll send off blood cultures, a urine specimen as well, and get a chest x-ray initially. Typically, you can isolate the specimen from those. And then obviously, as we mentioned, x-ray is not the best thing. CT scans can show you some bony erosion and some soft tissue, but typically what you're going to do is get an MRI scan with contrast, and that's going to be the best image for you, kind of demonstrated here. This is actually a patient that we were consulted on. She was 58, otherwise fairly healthy, but on chronic steroids, which really was a sort of real setup for her. She presented to the ER with fevers and back pain. She was otherwise neurologically intact. Thankfully, they got an image study here. And what she has is both L3 and L4, as you can see here, which are highlighted. 3 and 4 are both involved. You can see the bony erosion through here. The disc space is involved as well, and she's got an infection. Thankfully, she doesn't have any canal compromise here. There is space. You can see the nerve roots fairly well. We talked about the surgical options for her. She could have surgery or continue to monitor the symptoms. Because she was neurologically intact, they were able to isolate a bug. She opted for just bracing. And so I braced her for 6 months. This is what her CT scan looked like when she came in. I was worried about this space here and whether it would actually be able to fuse together or heal. I thought she was a little bit unstable, but she was actually doing reasonably well with pain medications. So, that was her choice. I said that's fine. And she actually, 3 months later, went on to start demonstrating some fusion. So she actually did fine. And I've seen her, and she's actually done great. So you don't have to go in there and operate on everybody. And this is typically the end result here. They'll just end up fusing. If the infection is treated, it'll typically just burn right out. Conservative intervention is typically recommended, as I mentioned, biopsy, cultures, IV antibiotics for at least 4 weeks. I think sometimes they're doing 3 months, and then they'll do immunosuppressive therapy for maybe even a year if it's not treated completely with just oral antibiotics. And orthosis, so some type of bracing to sort of, part of the treatment of the infection is immobilizing that space. If it continues to remain mobile, sometimes the infection has a harder time clearing. So bracing is one of the key parts of helping treat with the infection. Pain medications, muscle relaxants, very helpful because this can be extremely painful for patients. Selective surgical treatment, if there's a large abscess, sometimes we can have IR stick a needle in it with a drainage bag and let that thing decrease just to help decrease the overall burden of the microbes. If they have a kyphotic deformity where they're leaning forward and having spinal cord compression, they may need possible spinal cord decompression. And if there's epidural space involvement, as I mentioned, or if they have any type of neurological deficits, you're going to want to do surgery on them. And like I mentioned, most of the patients actually do well and go on to fuse 50% in about 1 year. And really the overall case of permanent deficits is fairly low. This is another consult I got, a 66-year-old gentleman who was a paraplegic, came in with abdominal complaints. He had some sensory function, he had no motor function, morbidly obese guy who was intubated in the ICU. This is what his lumbosacral junction looked like. Big, huge phlegmon, infection, inflammatory process, and you can see the bone is almost completely eroded within this area. We actually opted not to do anything with this patient. He was such a high surgical risk. This was going to require a general surgeon to give me an anterior approach, but the blood vessels and everything were going to be just completely socked in there, and they thought the risk of him actually dying on the table was extremely high. So there was nothing done for this patient. I actually have not seen him back, unfortunately. I think he's been dealing with this for actually 2 years by the time I got involved. This was a study done by 7 Cleveland sort of area hospitals. They looked at overall vertebral osteomyelitis long-term outcomes, and they looked at 253 patients. And what they actually found out, just in terms of retrospectively studying these, was they followed these patients for 6 years. They gave antibiotic therapy for at least 4 weeks. And in terms of surgery, there was an abscess drainage in 85 of the patients. They had to remove compression of the spinal cord and cautery equine nerve roots in about 48 of the patients, and went on to do spinal stabilization with hardware in about 32 of the cases, so not a whole lot of them. And overall, the clinical outcomes, the mortality rate was 11%, which was surprising. The residual disability was 30%, and the relapse was about 14%. And the reason that they actually thought that their outcomes were not that great compared to what we see in the community is because there was an average length of duration for transfer of the patient from a small community hospital to Cleveland Clinic and Main Hospital of about 20 days. So by the time the patient really failed, they got them over to the definitive therapy. So, if you're going to get involved and want to treat these patients, you have to do it early. You can't sit on a patient for 3 to 4 weeks before you decide to do something with them, especially at that point it becomes a real emergency and you're going to sort of, the benefit to the patient is not there anymore. Laboratory markers outcomes, unfortunately there's a fairly high rate of negative cultures from IR biopsies, 10 to 30%. But overall, I think the ID folks will typically treat them with a standard course of antibiotics, regardless if they can't get it, cefazolin versus vancomycin if it's post-operative. And typically what you'll do is you're going to want to follow the ESR-CRP, obviously imaging studies as well. If it's maintained high levels of inflammatory markers and not coming down after about 4 weeks of antibiotic therapy, you're going to be worried about possibly a treatment failure or possibly treating the wrong bug or something that's developed a resistance. So this can help sort of evaluate the overall effectiveness, and I think that's typically what the ID doctors will do for us. Move on into spinal canal infections. It's epidural abscess. We see quite a bit of these as well. First described in 1761. Dandy, one of our forefathers in neurosurgery, talked about it in 1926. The mortality rate back then was 80%. Only about 4 of 25 patients were treated surgically, and most of the time it was made at autopsy, which is not where you want to find out. The overall incidence nowadays is about 1.2 cases in every 10,000 hospital admissions. I think we see actually more than that around here. Mortality rates range from 5 to 32%. That was back in 2002. And outcomes remain poor. This is again epidural abscesses. And typically what you're doing is you're looking at sort of the location of the abscess, whether it's going to be anterior or posterior to the overall spinal cord itself. If it's posterior, typically that's going to be hematogenous spread from some type of remote infection, but if it's going to be in the anterior cord, it's typically coming from adjacent infections like in the bone itself, and I'll show you a picture of the difference between the two. And I talked about the symptoms earlier about bone infections. It's very similar for epidurals as well. Back pain, obviously if they have neurological deficit, you can want to image the patient, but fever, that's really the trifecta of things that you're going to be looking for and should be sending out some alarms in your head. Typically we don't send out ESR and CRP when people come into the ER with back pain, so obviously these are markers you're going to check when you get the imaging studies that tell you that there is possibly an infection. Obviously people can come in septic, they have meningeal symptoms, stiff neck, high fevers, altered mental status. Dysfunctional bladder function is obviously an emergency, and cord compression can continue if it's not treated promptly, meaning given antibiotics. And here's the difference between that ventral versus that dorsal infection. This is a ventral epidural infection, which is coming contiguous tissues from the bone, versus the hematogenous spread typically from a remote infection. This is a dorsal, behind the spinal cord infection, epidural, and you can see the difference here between the two. There's typically a progression of stages. It starts out with back pain, which is localized to that specific vertebral level, and then it moves on to possibly some radicular pain. If it's in the lumbar spine, it might have shooting pain on their legs. We see thoracic infections. They'll talk about this sort of low-grade rib pain, shooting pain around their chest. Oftentimes, these people end up getting a full cardiac workup. It ends up being negative, and it turns out they've got an infection in their back. And just like I had that yesterday in my clinic, then they progress obviously to motor and sensory deficits, sphincter dysfunction, and then obviously if it's not treated, they can go on to full paralysis itself. Correct diagnosis missed in about 30 to 60% of the cases, which is unfortunately higher than what we would want to see. Diagnostic choice again for epidurals, MRI with without contrast. I don't know if you can appreciate this, but there's a very large compressive mass here behind the cervical cord. It's impressively pushed forward from some type of fluid collection. If the patient can't have an MRI scan, if they have a pacer or some type of stimulator within their body, you can do a CT myelogram. It's not completely contraindicated. Obviously, you have to be very careful in terms of not getting into the dural space because you don't want to spread that infection into there. But typically, we can also isolate it with a blood culture. We'll come back about 60% of the time positive. Treatment strategies, obviously emergent surgical decompression if there's some type of neurological deficit. Typically what we'll do is a CT-guided needle biopsy and then IV antibiotics if the patient is a high-risk surgical candidate. And really the time lapse for when people come in, this is kind of alluding back to that study that they did. If somebody's been paralyzed for 3, 4, 5 days, there's no real need to be taking them to surgery emergently at that point. Kind of the cat's out of the bag. If you're going to get to patients, sometimes we talk about a 6 to 8 hour window, maybe if within 24 hours if you can get to them soon enough, to actually make a difference from a surgical standpoint, to actually get some sort of function back neurologically. And of course, your ID colleagues will help ensure that your coverage is appropriate with the antibiotics. Progressive neurological deficits, obviously emergent decompressive surgery. If they have progressive deformity, meaning if that lady that I had monitored, I followed her with x-rays every month to ensure that she wasn't developing a kyphosis. If she would have developed any progressive deformity, then I would have taken her to the OR and stabilized her as well. And then obviously radiological evidence of continued symptoms. You can do a percutaneous drainage or infant blood cultures with IV antibiotics. We sort of talked about this. This is the gentleman that I got a consult on, 58-year-old gentleman, been treated by his PCP, had a several week history of flank pain, and was treated for a urinary tract infection. Obviously, it's kind of the same complex of pain. He had back pain. They thought maybe it was a pyelo that had developed. His kidneys were infected. Then the problem was he developed 24 hours of urinary retention and reaction, couldn't pee for 24 hours, came to the ER, and they got an MRI of his back, and he had an osteomyelitis going on right here of T8, T9 with the discitis. He had a large compressive epidural abscess. You can see the spinal cord right here. This is the abscess right here, compressing his spinal cord impressively. We took him right to the OR immediately. We did decompression here. I opted not to fuse him because of hardware with an active infection going on, plus it was thoracic spine. And this is what the picture looks like here. His cord is completely decompressed, and he actually gained his neural function impressively. Thankfully, he was back to normal after the next day. He's actually doing well. So sometimes you have remarkable outcomes which are making you go to work every day. Subdural abscess, this is not that common. We'll just quickly touch on it. Extremely rare, described in 1927. Typically, again, this is some sort of hematogenous spread from a distant infection, not typically adjacent. That's much less frequent. It can be from a dermal sinus, and sometimes people are born with a dermal sinus. When they're born, where it's a direct connection from the skin right into the spinal canal, it hasn't been completely closed off. And so you can develop this just track right into the subdural space. Obviously, we can cause it iatrogenically with a lumbar puncture or some other device. And typically, it's Staph aureus, which is a common pathogen from the skin. Fevers, spinal radicular pain, neurological deficits, again, motor deficits, sensory deficits, and what we heard about sphincter disturbance as well. Very similar progression from a spinal epidural abscess as well. And typically, the duration of symptoms, acute is less than 1 week, subacute 2 to 8 weeks, and chronic being more than 8 weeks in terms of defining how long it's been there. This is very similar to the subdural and epidural and osteomyelitis diagnostic MRI or a myelogram. And this is what an x-ray on a patient. This was, what you can see is a little bit of disc collapse here on an x-ray of a patient, erosion of the end plates, bridging osteophytes. You question what's going on here. The patient presents with fevers, back pain. You get the MRI scan, you can see there's an infection going on here as well. If you can appreciate, the spinal cord here is actually outlined by an infection here. You can see this white enhancement within the canal, enhancing the nerve roots and the spinal nerve roots. And you have sort of this haloing appearance of the infection actually within the spinal dura itself. And this is what it looks like as well. And this is a pretty impressive infection within the canal. You can see this big fluid displacing the spinal nerve roots as well. So much different appearance than an epidural or bone infection. And finally, the last topic, intervertebral disc space infections, iatrogenic, meaning things that we cause by ourselves. There's two types. There's one called a septic, and then there's the avascular necrosis type. That's from the adjacent level of vertebrae, or what they call chemical discitis. Typically, it can occur from invasive diagnostic procedures like a lumbar discogram can cause it 0.6% of the time. Obviously, there's surgical discectomies. It's about a 1% infection rate. Or if you place hardware in there like an interbody fusion, 3 to 13% reported in the literature. This can present a couple weeks after your procedure itself. Your threshold will be a patient that presents with continued pain or muscle spasms despite having surgery. Typically, it improves with rest because that abnormal motion in that infection will cause that pain. So they really like to just lay motionless. The increased motions will cause the pain. And a positive straight leg raise, so if you just take the patient's leg and you extend their leg straight up, they develop that shooting pain or that extreme back pain. Problem is, sometimes patients don't present with these classic symptoms. The post-op for the patient, fevers. We always worry if the patient comes back with a fever. Sometimes it could be a pneumonia, but it obviously could be a discitis. A delayed infection in staph epi or other sort of lower organisms as well. BMP, which is an off-label use, and sometimes or on-label can cause an inflammatory response, and so you're not trying to figure out if it's just normal inflammation versus an infection itself. And sometimes ESR, CRP are elevated anyways because they're in the postoperative period and they're still just improving, and so you're not sure if it's because of an infection or simply postoperative recovery. Things that put you at higher risk postoperatively: multiple surgeries. Open drain, I would disagree with this necessarily as being a causative factor, but some people say that it is. Fracture patients, as I talked about, internal fixation. If surgery lasts greater than 5 hours, puts them at higher risk. So these big scoliosis cases that we do are much higher rate. Sometimes the hardware, like View was talking about, these very frail older ladies, you put the hardware in and you can actually feel it underneath their skin. I've seen one lady who actually broke down her skin right over the hardware, through her brace. It's a real mess. And obviously malnutrition, immunocompromise, and obviously we can do the similar tests as we've done before. This is a gentleman who had back pain. He had septicemia from an IV site. There's some erosion here of the L5S1 disc-based end plates look ratty here down below, and an MRI scan shows that he's got an active infection going on here at that disc space itself. So the final topic, more so for the surgeons, is safety of instrumentation of spinal infections. The patients that had surgery with instrumentation in one study in 2006 demonstrated improvement versus statistically better than patients that were just treated conservatively. Obviously, this is for patients who had surgery, not just patients who were treated conservatively in terms of surgical outcomes. If you don't do instrumented surgery, sometimes you worry about whether you destabilize your spine further by doing the decompression and not actually stabilizing the components itself and just putting them in a long-term brace. And that can lead to other comorbidities for the patients, DVTs, pneumonias, things like that. We want to get our patients up and moving as soon as possible. That helps with their overall recovery. There's obviously multiple different approaches we can use, whether it's from the front or the back, now the side as well, in terms of cleaning out the area. What can we put in there? We can put in different types of graft material, where it's autograft versus allograft. There's not necessarily a difference between the two. We also have PEEK cages, plastic cages, which we can use, and there's been success and safety demonstrated with that, so that's also an option. And typically, titanium is a lot of the products that we use nowadays. It's in theory the bugs don't stick to the titanium versus stainless steel, what they used to put in. So even when we get an infection, ID wants us to pull the hardware out. We don't have to do that anymore necessarily. They can actively treat it, and sometimes what we'll do is we'll leave it in for 1 or 2 years. Once they've fused or gone on to do well, we can actually go back in and pull the hardware out as well. So that's always an option. Or like in the guy I just didn't put any hardware in just to avoid that whole discussion. And that's pretty much it. Our pearls: aggressive debridement. If you're going to do surgery, do it aggressively. Reconstruct the column if you have to, if they have instability and you need to. If you don't want to do the instrumentation at that time, you can wait and come back once the infection is a little bit more cleared. Titanium is okay. And some people ask about the use of BMP. It's not an on or off-label use, but some people actually think that the use of BMP is actually fine to use in inflammatory and infectious processes. And that's about it. Thank you very much.